interinstitutional project between Salzburg Research and Paris-Lodron University Salzburg. Dr. Carrozzo's background is in statistics, in particular non-parametric statistics and resampling techniques, with many years of experience in applied statistics in the healthcare and life sciences. Dr. Carrozzo previously also worked at our institute, so it's great to have you back for our symposium and hear about your work, examining whether the N of 1 study design could be an attractive option for us in digital health. Thank you for joining us today, Eleonora, and over to you.
Thank you, Tino. I try to share my presentation now. Can you see my screen?
Yes, we can see the presenter's view perfectly. Thank you.
Okay, perfect. Thank you very much. Thank you for the introduction and good afternoon, everyone. Well, today we are going in this talk to take another look at the N01 design. So why another look? Well, because the N01 study design is currently receiving broader attention in healthcare research when assessing the effectiveness of digital health intervention for its ability to test interventions on an individual level. Well, the background behind this talk is that if on the one hand, these new and emerging digital innovations and technologies can transform healthcare into a model that is increasingly patient-centered and transparent, on the other hand, we wonder, how do we address the pace differential between this rapid advancement of digital technologies and the necessity of rigor scientific rigor in evaluating the quality, safety, and effectiveness of new digital health intervention? We know that the highest quality experimental evidence is derived from the randomized control trials, the RCTs, but it is also well known that this study design can be very resource intensive in terms of time and costs. So we wonder if there exist novel or alternative study designs which allow us to evaluate digital health innovations more efficiently. So let me briefly recap what a randomized control trial is and how it works. So supposed to have two interventions, A and B, typically control and experimental conditions. And yeah, we can summarize our research question by the following set of hypotheses. We have a null hypothesis H0, which states that the two interventions are basically equivalent, so there is no difference between the two interventions, against the alternative hypothesis, which states that the two interventions differ by some specific amount, delta. Now, following an RCT, a certain number of subjects are randomized to receive one of the two interventions, forming a control group and an intervention group. Then we identify an outcome that is thought to reflect the effect of the intervention. And on the basis of the nature of this outcome, and on the basis of some parameters from the population under investigation, it is possible to compute the sample size requirement. A sample size is the number of subjects that have to be enrolled in the trial in order to answer the specific research question. And recruiting subjects is crucial in a study design, a trial, because it can be very time-consuming and also costly. So from now on, when we talk about efficiency, we refer to sample size requirements. Here we can see some examples of different outcomes, and we can see that on the basis of the corresponding parameters from the population and on the basis of the specific difference that we want to detect, the sample size requirement can be very high, even for those reasonable differences. So actually exist many alternative study designs to the randomized control trials developed for evaluating digital interventions. And some of these study designs are developed in this field with this purpose. Some others are actually already existing study designs developed in the past in other fields, but that can be applied in an innovative way in this context. Today, we are going to have a look at the N01 study designs. That is a particular case of the repeated period or replicate or multi-period crossover design. Let's see more in detail. N01 refers to those studies where a single participant is randomized to a sequence of interventions, typically an experimental versus a control condition. So for the randomized control trial, subjects were randomized to receive one of the two interventions. Here, one subject is randomized to a sequence. So he or she receives both interventions in a random order. A typical example can be testing the effect of a drug on a patient by alternating between the drug and placebo and observing changes. So here the effect of the intervention is compared with the control condition within person. Why I mentioned the link with the multi-period crossover design. Typically, a multi-period crossover design in a multi-period crossover design, subjects are randomized to a sequence of interventions, so control conditions and then intervention, or vice versa, and repeated for many cycles, many blocks. Basically, an N01 trial is a multi-period crossover design applied to one subject. Of course, these block repetitions might correspond to higher information about the within subject treatment effect. And typically, this kind of design in which subjects serve as their own control can control for many sources of bias, such as subject heterogeneity or comorbidities, leading to a more robust estimate of the intervention effect. So why considering an N01 study design? Well, first of all, there is a growing recognition that one size doesn't fit all, and personalized research is becoming more valued. N01 study designs support treatment tailored to individuals, and N01 designs are valuable in tracking progress for individuals. Indeed, here we can see also some example of applications of the N01 study designs, for example, in medicine for pain management, symptom release in chronic disease, or personalized drug response. In psychology for behavioral interventions for habit formation or anxiety treatments, and in education for individualized teaching strategies and tracking student progress. But it is worth noting that while a parallel RCT and the crossover designs, including the multi-period crossover designs, aim to estimate the average effect of an intervention in the population. The N01 study design strive to identify the optimal intervention for a single patient or participant. Nevertheless, if different N01 trials share the same protocol, results from single N01 studies can be combined in order to estimate a population level intervention effect. So now the question, can an aggregate approach of N01 trials lead to the same conclusion as an RCT or a crossover trial more efficiently? So let's consider this example in evaluating digital health intervention in cardiovascular care. Maybe some of you already know the Active Plan tool. The Active Plan is a digital health intervention developed to support patients in establishing regular physical activity habits following completion of a phase 2 rehabilitation program in the Austrian healthcare context. The intervention is basically a digital plan calendar for regular physical activity implemented into an app. And patients and healthcare professionals agree on a physical activity plan, and reminder notification on the days with the planned physical activity session can be sent automatically by the app. So in order to assess whether this intervention leads to more physical activity with respect to the usual care, that is no digital technologies involved, a 12-month trial has been planned. The outcome that can be considered to reflect the effectiveness of this intervention is the daily minutes of moderate to vigorous physical activity assessed by accelerometry. So which study design to use? If we go for a traditional randomized control trial, so participants randomized to the intervention, that is the active plan, or to the standard care, it is possible to use data from completed cardiac rehabilitation trial to compute the sample size requirement. And we can see that the sample size necessary for each group should be 652. That is a huge number. So let us consider also some alternatives and possibilities. For example, fixed the period of 12 months. We can also consider the two-period crossover designs, where subjects are randomized to receive a sequence of treatment, so the standard care or the active plan, and then the active plan or vice versa, and following 2 6-month period accordingly. Or alternatively, following a series of N01 trials where subjects are randomized to a sequence of interventions, so active plan and standard care, or standard care and then active plan, and follow 2-month period of exercise, and then repeat this period for 3 cycles. In order to compare the performances of the 3 methods, of the 3 approaches, we performed a simulation study in order to simulate also different scenario in terms of between subject heterogeneity. So we consider the situation of between subject homogeneity, a situation with a weak between subject heterogeneity, and a setting with the strong between subject heterogeneity. And we also simulate a carryover effect. A carryover effect is a residual effect of the treatment, of the interventions, which perceiving the immediately succeeding period. And yeah, as method of aggregation for the N01 trials, we consider the meta-analysis of summary data. That means that each single N01 trial is considered as a single study in a meta-analysis. So we perform the meta-analysis of N01 trials. And on the right side of the slides, we can see the results of this simulation study, where we reported the empirical power for the three different scenarios, for the three approaches, for different sample size considered on the x-axis. And the red line represents the desired power of the 80%. And we can see that the meta-analysis of N01 reaches the desired power earlier with fewer participants with respect to the other procedures. Actually, the other procedures never reaches the desired sample size, the desired power, sorry, for the sample size considered in this study. Indeed, the sample size required necessary to reach the 80% of power for the other two approaches in the different scenarios goes from 300 to 420 for their randomized control trials, and is around 150 for the crossover, against the only 40 required by the N01. The results of this simulation study is reported in this manuscript that is currently submitted at the second stage of revision to Biometrical Journal. So let me summarize and conclude. Well, the N01 study design presents several advantages. N01 trials are particularly promising due to their ability to test intervention on individual level. Furthermore, when properly conducted on a sample of subjects from a population of interest, it is also possible to estimate population treatment effect by aggregating results from single N01 trials. And we saw that it resulted more efficient than a parallel design because each participant serves as their own control, reducing the variability and consequently also their sample size required. We also say that repetition of the cycles might lead to higher information about the within subject treatment effect and consequently to the overall aggregating result. And this led also to be more efficient respect to the crossover design. But we have to consider also that this study design presents some limitations and some considerations have to be made, because this number of cycle repetition that might correspond to smaller sample size requirements could also result in a longer overall trial time. In our example, we had a fixed time, so it was not the case, but it is not always possible. And so it is important to keep it in mind. And another thing is that the treatment effect is thought to be relatively stable in time with an immediate effect on the outcome. And this is also the reason why it fits well in the situation where the treatment results in a concurrent symptomatic improvement rather than a permanent change in disease status. And yeah, we talked about carryover effect and we considered it in the simulation, but in a very simple way. But sometimes a carryover effect can be more complicated and can affect the results. There are also other methods that allow to manage a carryover effect, but sometimes it's also necessary to apply a washout period between two succeeding periods. And finally, we have to think about that withdrawn intervention could be not ethical when the intervention aims at disease status change. So some ethical issues can arise and that have to be taken into account. Well, that's it from my side. Thank you for your attention.